going to see what happens. We're going to say yes, but. We're going to see what happens. And we're not only going to see what happens on the effect, we're going to see what happens on the cost savings, the impact, both positive and negative, on different budgets in the health system. Because quite often, the reason that a technology is said to be very valuable and worth funding is because it's going to make savings elsewhere in the health system. And so, moving into a conditional world, we're going to have to get quite sophisticated about capturing what we expect to happen to different budgets so that we can then monitor whether it does happen. So I see budget impact analysis moving from being something that's done to inform local budget holders and implementation people once the decision has been made, moving to be an integral part of the evidence base for the HTA decision. And so I'm now starting to engage a bit more with what would be good practice in budget impact analysis. And I would encourage you to read up in this area. So what am I going to talk about? Cost effectiveness analysis, budget impact analysis, and procurement. So I've already said about how I think it's important to procurement. I'm going to very briefly say how it's different from cost effectiveness analysis, but it's a necessary complementary piece of information. And then I'm going to outline a framework for thinking about budget impact analysis that's taken from the ISPOR good practice guidance on budget impact analysis. And I've used that paper to structure this presentation today. Largely I agree with it, but in one or two places, and I'll highlight these issues to you when we hit them, I think it's already out of date and it no longer represents best practice. So I'll highlight that to you. But that said, I would recommend that if this is part of your business, or if you are in HTA and don't currently have to worry about budget impact analysis, go and read this paper. You need to start understanding this part of the evidence base. Because it's not on your desk today. I think it will be on your desk 12 months from now as an integral part of the HTA evidence base. Okay. And then at the end, I'm just going to flag up that we are seeing the emergence of standardized approaches. And that might be something that we here in Alberta want to think about. If we know we're going to do it a lot, then we should agree what doing it well looks like, and we should standardize our processes for doing it. So I'm just going to show you a little bit of what the UK has done in that process, in that space, and you can go away and trawl through the website and see what you think of it. I don't think it's the finished product, but it's some interesting stuff there. Okay. So this is the paper from ISPOR, published in 2014, reporting a task force that worked from 2012 through most of 2012. So well worth a read. So you will hopefully remember this diagram that I presented earlier in this series, explaining how cost effectiveness analysis identifies the opportunity cost, and from that the threshold at which we define good value. And we should adopt technologies that are good value given that threshold. And you'll remember I said that the more you displace from your current budget, the higher the threshold, well, the higher the bar, but actually the lower the cost effectiveness is going to have to be in order to be good value. So that instantly gives us a reason to be concerned with budget impact. Some technologies have such a large budget impact that it is not appropriate to apply our standard cost effectiveness threshold. So we talk about whether technology's budget impact is marginal or non-marginal. If it's marginal, it's just swapping this for this. That's fine, our threshold is fine. But Some technologies have such a large budget impact, they're not going to just displace this, they're going to displace this, and maybe even this. So the one that probably is coming to everybody's mind, it was in the news this morning for BC, is oral therapies for hepatitis C. If we paid for every person who was infected, we'd probably be looking at a threshold somewhere here. I mean, the total budget impact is so large that even though it's cost effective if it was a marginal technology, it's not marginal. The sheer scale of things it displaces means that it needs to be much more cost effective for us to actually adopt it for all patients who could benefit. And so instead, quite rationally, what has happened is the reimbursement decisions have been for subgroups, smaller subgroups where the benefit is larger and the budget impact is sufficient that it's marginal, and we can work with our conventional cost effectiveness thresholds. So that's the first reason for knowing about budget impact. So how do we think about it? Well, we have to start off by thinking about the current state of affairs. We have our total population that we're caring for. What proportion of those are sick? Within that sick population, what proportion are target for this therapy? Okay? Which current therapies would it therefore substitute? Okay. So what are we spending on these people now in all of our different budgets, our hospital care, our ambulatory care, our drug budget, our family medicine? Where are we spending the money on the target population now? Because if we can't describe reasonably well how we're spending money on these people currently, we're not going to be able to identify the budget impact. All of that allows us to get to a current cost of illness. Evidence required to characterize these things? Well, incidence and prevalence. So if it's a short, a disease of short duration, we're interested much more in incidence. But for chronic conditions, we need to know about the incidence and the prevalence, because it's not just the flow, it's the stock. So we've got to understand the stock and the flow of patients into the sick population. And then we've got to understand what resources we use to diagnose them into the target population. So everyone with breast cancer, yes, but then we do the pathology to understand what type of breast cancer. Are they HER2 positive? Is it estrogen resistant? So understanding how we then unbundle our sick population into the target population for our condition. Then what we do with those people. And this is one of the first ways in which the evidence we use starts to divert from a cost-effectiveness analysis. Often with a cost-effectiveness analysis, we'll have one or two, maybe three comparator treatments to the current treatment. And we look at them as pairwise. Is it better than A? Is it better than B? Is it better than C? We want to know how many people get A, how many people get B, how many people get C, because it's highly likely that the incremental cost, just in terms of price, for our new technology is not the same for A, B, and C. So we actually need a much more detailed and granular understanding of what's happening in practice now in order to get a robust baseline from which we can capture the expected budget impact. So we really need to understand how we currently treat them, and it's not likely to be just one way. So we capture the resource utilization in all the different budgets that we have, and we attach unit costs to them. And that allows us to identify in a reasonably robust and transparent way how we are currently spending our resources on the target population for the technology we're interested in. Now we're interested in how the technology will change things. Okay, so will it change the prevalence? Are we actually curing the disease? Again, that Hep C. We are reducing the pool of infected people. So actually, if we do it on a sufficient scale, we're going to reduce next year's incidence as well as this year's prevalence. So understanding how we're impacting on that. Then we need to understand whether we change the diagnosis and treatment. Well, again, let's use Hep C as an example. We used to have just Hep C. But now we have, I think, six genotypes. So that's, again, a different test that we now need to do, because not all of the new oral Hep C drugs are licensed for all genotypes. So suddenly we're changing what we do here, and we're opening up our target population into a number of subpopulations, and we're doing that by an additional level of diagnostic testing. It's not just if you've got the Hep C virus, it's what's your genotype. And then given your genotype, which of these drugs, or these combinations of drugs, are we going to give you? Okay? So how does it change that? How does that then feed into changes in other budgets? Hep C, thank heavens, these are largely curative. In the plus 90% of patients, we are expecting them to be curative. So the follow-up management from specialists that we were expecting to have for these people on an ongoing basis, well, we're not expecting to have to monitor the development of their cirrhosis because they've been cured. So we're looking now at changes in the hospital resource utilization, changes in MD visits and associated diagnostic tests. Certainly a huge change in treatments because we're not expecting to have to manage their cirrhosis. Never mind having to manage their liver cancer if they progress far enough. So we're looking at a large number of budgets that are going to be different here. And then, of course, we've got the cost of the new therapy. So your cost effectiveness model will give you an estimate of the cost of the new therapy. It will give you some insight here. But it won't really give you great details on these in the same way because it's not setting out to get the volume of the patients in your whole population who will flow through these things. It's interested in estimating the expected cost per person, is what a typical CEA does. So we go through those, and that should put us in a position where we are modeling a future. We're saying this is what we expect next year to look like because we have adopted this new technology. Okay, our total population, well, it may be slightly bigger because some therapies actually stop people from dying. Okay, so it's marginal, arguably, but our total population may not be just a linear extrapolation of this year's population. For some of these therapies, we're looking about keeping a substantial number of people alive who would otherwise have died. So we have a new idea of what our total population is, a new idea of what our sick population is. Again, to repeat myself, which I do a lot, if they're not infected, they don't infect others. And so our model of how many people with the condition are going to be there next year could well be very different. we've broken out our target population. It's not a clump anymore. It's a number of differentiated target populations, and because they're targeted by different drugs, actually the costs for each of those, the budgetary impact for each of those, is going to be different. Yeah? And because there is some variation in the drug's effectiveness in Hep C, we'll see some difference in each of those subpopulations in their resource utilisation as we look to the New World Order. And therefore, we have a new estimate of the cost of illness, and the difference between those two is the budget impact. This is all a prediction. This is one half of what we think we're buying and what we're spending to buy it. Please.
Quick question. Is this model able to predict for how long could there be a period of what I might call double funding? So you're still funding, your old liver cancers and cirrhosis.
I think that's a really good point.
And then at some point in time, you should expect this will go down. Like, I don't know.
Well, I think that's a great point, and I'll come back to it because that's one of the other ways that it's different in budget impact and cost effectiveness analysis, because there's a number of factors that will impact upon what's the front end growth in budget and where that's taking place, and what's the back end growth in savings and where that takes place. A cost effectiveness analysis, it says the current value of the lifetime costs and effects, the difference between them divided by the difference in the outcomes, gives you your ISA. And that's it. We put a huge amount of evidence into the model in a cost effectiveness analysis. And then we produce essentially two figures and present you with a ratio, and then we might do some uncertainty analysis. But it's highly aggregated, and it's brought everything down to the present day, even though we know they don't all occur today. It's spread out over time. And budget impact analysis is one of the places where it's really important that we recognize that and we don't aggregate. So I'm going to say a little bit about timelines and cycle length for budget impact that's a bit different. Okay. So, things to think about. Health system characteristics and the perspective that you're building your budget impact model for. So, conventionally, again, cost-effectiveness analysis, we assume we have a single decision maker who's got a single budget. But budget impact, it starts to become very important to understand that's not true. Yes, Alberta Health will cover the drugs inpatient and certain other categories, but lots of us also have some version of private insurance to cover our drug costs. That will impact upon uptake. If you have a health system that's structured with multiple funders, then actually assuming that you're going to get 100% uptake is going to lead you to make an incorrect and almost certainly substantially overstated estimate of the budget impact just for the immediate drugs. Depending upon the nature of the insurance, you may be a patient may be able to afford the copay on the current first-line therapy, but not the copay for this new first-line therapy. Understanding what portion of people that is in your target population is really important. And if you don't know and you can't find out, then at least explore it explicitly in a scenario analysis. Okay? So the structure of how your healthcare system is financed matters in a budget impact analysis in a way that it doesn't matter in a cost effectiveness analysis, or is not treated as matter. What's the relationship between the financing and the take-up of therapy? It will also express itself in, those factors will determine what your current treatment mix is. So again, you can't assume that everybody's getting the current best therapy and it's just going to be a direct substitution. You're going to have a portfolio of therapies currently used for this indication, and there's going to be variation in the degree to which the new therapy is going to successfully substitute for those therapies. It needs to be thought through. And that, again, will have implications for the expected indirect effect of the technology. So if not everybody uses it, then not everybody gets the mortality benefit, then the population doesn't grow, driving additional demand for other, or failing to drive additional demand for other healthcare services, what we tend to talk about as either indirect budget impacts or unrelated medical costs. So just asking yourself this question at the bottom: what is the perspective of the budget impact analysis? Does it have any implications for access issues? Does that flow through to what are actually going to be the real budget impacts rather than the hoped for? Sort of said this already. Not only can the portfolio of interventions be different from what you expect from a clinical guideline about best practice, but actually it can change, and it can change in two ways which we routinely ignore in cost effectiveness analysis, and I've long thought we shouldn't, but we do. One is therapies can go generic, and secondly is new therapies can come on the market. So, back to Hep C. The first oral Hep C was licensed in 2011. They ceased production in 2013 because the next generation were so much better, they just got wiped out. Their sales plummeted. So you have to do a little bit of crystal ball gazing. But it's not. Actually, you need to look into the literature. You can do what's called technology landscaping. Some people call it horizon scanning. So you look, what's in phase 3? What's in development that over the time horizon I'm interested in could come and impact upon this therapy? Because once you've let one all-oral high-cost Hep C drug into the market, it's quite hard to say no to the next, even if it's only $2,000 or $3,000 more expensive, but you multiply that $2,000 or $3,000 by all of your Hep C infected population, and that's again a system-breaking budget impact. So looking forward over the time horizon that you're modeling for the budget impact and asking, will some things come off patent and save me a shed load of money? Will other things come onto the market that are patented and again push this budget upwards in ways that I didn't really expect? So thinking through that is really useful. It's good to be clear when you're talking about direct budget impacts, which is your costs attributable to the management of the target condition, in order to make sure that you capture so this is original version of this is just the direct budget impacts. It's the difference in the costs of the target population that they're really in. But you need to think about the indirect budget impact, especially with these these truly sort of groundbreaking technologies. If you're keeping a bunch of people alive, well, nobody lives forever, and so we will want healthcare for something else. And understanding what timeline we'll observe that new demand for healthcare in is really important. And it can be really useful. Because it can enable you to identify where savings are going to occur that you can use to fund the additional healthcare. This breakdown can be very useful. But just knowing that you have to think about what the investment in the target population means for unrelated healthcare costs, and I would say as more and more of these things are aimed at the elderly, unrelated social care costs. You know, keeping people alive as they're older and older, given that their demand for hospital services goes up and their demand for social care goes up, it has implications that are worth thinking through, even if you cannot quantify them, to name them and say, these are things which we may wish to monitor to see if there's an effect, puts the decision maker in a much better position and reduces the risk of nasty surprises 4 or 5 years down the line. Right. So, time horizon. This is really important. Cost effectiveness is easy. The time horizon is sufficiently long to capture all expected important differences in health outcomes and resource utilization. Almost always a lifetime time horizon. That's 40, 50, 60, 70 years from now. Budget impact analysis is very much what's next year, 3 years, 5 years. Because to go further than that, we don't know what the external economic environment is going to be. We don't know what the political environment is going to be. We don't know what's going to have happened in healthcare more broadly that impacts upon the efficiency of the healthcare system and therefore what can be afforded. So you need to explicitly ask the budget holder who you're trying to inform and support, what's the timeline you're interested in? I remember 20 years ago when we were looking at adopting statins. They were the wonder drug of the mid-90s in the UK. And the problem with statins is the evidence at that time said down to incredibly low levels of risk, they were cost effective. But unfortunately, it was going to cost 500 million just to make them available to all UK patients who qualified on the basis of secondary prevention. And so we had to, literally we had to ask the Treasury, what timeline do you want to know about the budget impact? And they said, well, next 5 years or so, Department of Health, Treasury said, 5 years, what's going to happen over 5 years? Well, to get everybody in secondary prevention, or nearly everybody in the secondary prevention category, onto statins over a 5-year period, it's going to increase the pharmaceutical budget for the UK NHS by about 500 million. The total expenditure on statins by the NHS over the subsequent 20 years is massively larger. There was a political decision that we wanted to go down to, I think, a 3% over 10-year risk, whether you'd had an event or not. So again, those things changed. Lots of them went generic. Atorvastatin eventually went generic, and that changed the story again. But what was relevant to the decision at that time was over 5 years, as we build up and capture people as they come in, follow them up, get them on statins, how much it's going to cost. Cycle length, similarly, telling the Department of Health that it was 500 million over 5 years wasn't really useful, because they wanted to know that, but they wanted to know, right, are you going to get 70% of these people in the first 6 months of year one? Because they're already in touch with the health system, they see their GP regularly or whatever. Or actually, is this growth going to be kind of very linear over the... You have to ask the decision maker, not only over what time period, but what granularity of the accumulation of budget impact do you want, do you need? If the budget holder has to balance their books every quarter, then annual budget impact is not good for them. You know, it's got to be fitness for purpose. Understanding that you will get upfront growth before you see savings in other budgets, and knowing where in time these things occur. It's really important. Some of them are so far into the future that actually there isn't a budget holder who cares about them, to be honest. You know, I don't think the people who hold the budgets for treating cirrhotic patients are really worrying about their budget in 10 years' time when we should start to see a change in the flow. They'll worry about that probably 6 to 7 years' time as they figure out how on earth do I defend my budget, because I don't want to give it up. There's other things I'd like to do for my patients. You know? So understanding the distribution over time and the granularity of the description of that distribution over time is really important determinant of how useful a budget impact model is. Okay. So this is time dependency, again, that same point. The impact will be affected by new market entrants, end of patent protection, and bizarrely, you wouldn't think of, but actually exchange rate. You know, how many of our drugs are actually made in Canada? Well, you know, if they're not made in Canada, then they have to be imported, and they are going to be imported at varying exchange rates. So their actual acquisition costs are going to change. And that's true not just for the drug of interest or the technology of interest. Actually, it's true for lots of things that we buy in healthcare. They're not made here. You know, the cost of the UK NHS is going through the roof as the value of the pound goes through the floor. You know, it's a real thing. And understanding that. And again, we're not exchange rate experts. Okay? But thankfully, governments for different reasons do have models of what they expect the trend, the central trend over time for their exchange rate to be. We should use those when it's appropriate, when it's something we're importing. Our model should capture that cost. Discount rate. Cost effectiveness analysis, discount rates, really important. I published a paper on this very subject just the other week. I have yet to encounter a budget holder who works in anything but current dollars, because that's their budget. You know? So cost effectiveness analysis is very interested in value. But budget impact is interested in dollars and cents budget, their actual budget this year and next year and the year after. Telling them the next year's budget is actually worth 2% less than they think it is not helpful. It will just induce anxiety. And once they've figured out what you mean, they'll say, oh, I'm dealing with an idiot, and get back on with their job. So let's, quite simply, on this occasion and this occasion only, I will say, if you discount in a budget impact, you're doing it wrong. I don't care if it's 5 years from now. If you discount it, you're doing it wrong, and you're going to give the budget holder incorrect information. And at the end of the day, our job is to give them the best information we can, given what we know. So choosing to do something because it's theoretically correct from an economics perspective, but utterly wrong from the needs of the decision maker, is something we should avoid. So we don't discount in budget impact analyses.
Quick question on that.
Please.
Current decisions versus future decisions, should you include a discount rate? Because you might have options about when to implement.
So from if it's just the budget impact that's going to determine what you do, I think you should use the actual undiscounted financial values. Because if it's just the costs and it's the real budgetary, well, not real as in discounted, but the, I've forgotten the word, Gone out of my mind. Anyway, it's the actual billed financial amount against that budget in year 2 versus the billed financial amount against that budget in year 1. If you're taking other things into account that are about value, discounting comes into play. But if it's just a budgetary issue, I'm willing for someone to persuade me otherwise, but I have not found an argument why budget-based decisions, just budget-based decisions rather than value-based decisions, should use anything but the actual, the current value rather than the real discounted value. What was I going to say? Budgetary silos. So I flagged this up early at the beginning, really. I think this is one of the places where it's going to become more and more important for HTA budget impact analyses to pull out where the savings occur, where the increase in budgets occur, in order to support this more sophisticated conditional approval, value-based procurement contracting kind of world that we're gradually moving towards. Precision medicine. Precision medicine is going to play hell with lab budgets. We're going to spend lots more in lab. And we're going to get benefits in patients not being in hospital and not needing to go into nursing home care, not using the emergency department because they've got terrible side effects from these non-precision drugs. It's a really complex story from a resource perspective. And the overall conclusion that these are going to be valuable rests upon us being able to take those savings and reimburse them into the location where the investment has taken place, so that that budget just isn't in everlasting deficit. So we actually have to not only identify the budget silos and where the changes occur, but budget impact analyses that do that will be the starting point for conversations between budget holders about how resources are moved around the healthcare system. Because we can only get more efficient by reallocating resources to where they're more valuable. But if we don't know where they are, then we can't reallocate them. So budgetary silos is going to be a big issue. And I think this is one of the places where I diverge from the ISPOR guideline. The ISPOR guideline says you should construct your budget impact analysis so that whichever budget holder you're speaking to can pull out just what's happening to them. But that maintains silos. And it encourages decisions to be made from something other than a system efficiency perspective. You have to give each silo budget holder the information, but it has to provide all of it at once so that we can see where the differences are. Otherwise, I don't see how we're going to get to be more efficient. Uncertainty, and this is the second place where I diverge from the ISPOR guidance. The ISPOR guidance basically says there's a lot of this that's uncertain and difficult to get data on. So instead, we suggest that you basically use lots of scenario analyses. What if? What if? What if? Well, I have two problems with that. One is not all scenarios are equally likely. And we've had this argument in cost-effectiveness analysis. You need to provide some insight into the probability that a certain state of the world will occur, not enough to say that it's feasible. You're not helping the decision maker if you just give them a large number of feasible states of the world without any information on how likely those different states of the world are. We can only process, maybe up to 9 pieces of information simultaneously. That's the brightest amongst us. On Boxing Day morning, I could probably hold about 3, I think. it's we as analysts have a responsibility to make the burden on the decision maker as low as it can be in terms of that information processing. And so I think actually parameter uncertainty should still be done probabilistically, like cost effectiveness analysis, but you may need to use expert elicitation. So speak to the experts, the people who are going to make the decisions, who have experience in the space, and get them to tell you how likely they believe different states of the world are. Don't just say, well, I don't know which of them's going to happen, so I'll treat them all as equally likely, because that's not true. I just don't believe that that's true. What do we want to look at? Well, we want to look at utilization trends. So you won't get that instantaneous uptake of everybody. No, it's going to grow over time. Understanding what the determinants of that rate of growth is going to be really important, and you can model that explicitly. So you'd expect the budget to be different in year 1 than year 2, but you're not certain about how much bigger it will be. Obviously, the effectiveness, the adverse events, they're uncertain. The use of complementary and substitute treatments, that's uncertainty. How it impacts on life expectancy and therefore unrelated health, and I say social care utilization, that's uncertain. Time to generic substitution. We all know that there's a day when the patent is meant to lapse, but the creativity of pharmaceutical companies in putting off the moment when that actually turns into generic competition is quite incredible. And so we're uncertain about that type of stuff. So we should capture the uncertainty on these parameters using probabilistic analysis as we do with cost-effectiveness analysis. Just remember, I didn't give my second point. The second point, the second reason we use probabilistic analysis in cost-effectiveness analysis is actually, if you assume everything is fixed, you get the wrong answer. The deterministic model is only correct if it's a linear model. These models are quite complex. So actually, to get an accurate prediction of budget impact, you have to run the probabilistic analysis. So accuracy is an even bigger reason to do probabilistic analysis. Okay, not long now. So here's something called a budget impact curve. This is a model we just ran looking at impact on hospital inpatient stay. We have an expectation and we have uncertainty. You know, it could be that the inpatient costs go up by 6 million. Or, in the extreme, we might say 4.5 million. We think on balance, we're just about going to break even, 643,000. In providing this sort of information, we can start to do that thing or support that, what I was talking about, in terms of conditional contracting. We can identify a range of tolerance. So if we say, you know, plus or minus 10% is fine. If what we observe with hospital inpatient is in this range, plus or minus 10%, we're happy. We've got what we've bought. But then we can monitor to see at certain time points, are we outside of that tolerance range? You know, we can have a contract review point and say, well, if you're here or here at this point in time, here we might actually need to pay you some more money. It might be better than we thought. But if you've gone all the way up here, actually we want some money back. Or we might even say, you know what, we're going to withhold a portion of the price until here. And if you've delivered in the tolerance range, then we'll give you that extra bonus. So we can unpack to reduce the risk. Instead of all of the risk of the technology coming onto us as payers on the day we say yes, we can share the risk of it not being as good as we thought. But only if we have this sort of information and put it in front of decision makers. So I think this is an example. Sorry, you were about to ask a question. changed your mind?
I'm going to reserve it for
You're going to reserve it. Okay, that's all good. So, we also have structural uncertainty, which I think is appropriate for scenario analysis. Clinical practice changes, unfortunately. New drugs come online, new discoveries about best surgical approach. Clinical practice changes. We need to explore how changes in clinical practice would change the budget impact. And again, that's a place where you need to talk to the experts, the clinicians. What's coming down the line? What's possible that could change things? Restrictions on the use of technologies. Again, what's the, with Hep C, we reduced it to really quite a small portion. If that changes, say the price drops down and so we have more, but that means more people living longer and dying of other things, and so our indirect, unassociated medical care cost predictions could grow. So understanding those things is good to do with scenario analysis. So I think the only place that's really got into this in a systematic, standardized way is NICE in the UK. Okay? When they issue an assessment, a recommendation, they pretty rapidly produce these 4 sets of support tools: baseline assessment, so need, tools for auditing actual utilization, and costing tools. So you can go to this and you can put in the name of a guidance title, and it will take you to a link, give you a link for a website that takes you to the costing tools for that.
back to your previous slide. Is everything into consideration changes in funding models? So let's say we
All right.
move into something like accountable care organization, aid sharing, et cetera, et cetera. Does that ever have a place in budget impact analysis?
Okay, so if I was going to do one here in Alberta now, and I knew that there was an alternate payment plan in negotiation for that specialty, I would think it was incumbent on me to think through whether that would change practice or total volumes billed associated with the technology. So if it's real enough that it's in the policy discussion and there's public sort of target dates for implementation, then I think yes, we should. Huge changes like the Affordable Care Act, very difficult to predict. Certainly not quantitatively. You're going to, I think you're in the qualitative, descriptive space there. But fundamentally, if we can see something is credible as happening that we would expect to change the budget impact story, we should at least include an account of that for the decision maker. Yeah, that would be my position. So I did that. So summary, they are distinct from cost effectiveness analyses. Important to consider both direct and indirect. Time horizons, ask a decision maker. They're not going to be cost effectiveness analysis time horizons. Need to think about health system financing structures, how that is going to impact on uptake. The assumption that everybody who's clinically indicated will get it often won't hold. So you need to think about that. You need to think about what they currently get, because it's probably not confined just to the technologies that were included in the economic evaluation. I would say quantify budget impact by silo for all silos. Okay? And characterizing uncertainty in a stochastic probabilistic way, that's increasingly important as we move forward into this conditional payment procurement world, where what we're having to deal with has less and less evidence and higher prices. Those two things come together to mean we're more uncertain, and so we need to help the budget holders understand the uncertainty in their budget impact analyses that we present them with. Okay. So questions. I think we pause momentarily just to say thank you to the people online, and hopefully you'll log on for the next in this series in a week or two. Thank you for joining us.